Okay, I'm Chun-Yen Chiang from Chee Medical Center, Taiwan, Thailand. Thank you everyone to participate the TCTAP 2021 virtual convention case session 7 complex PCI. Another moderator is Dr. Nishina.
Tsukuba Medical Center Hospital.
Yes.
Okay, hi everybody.
And panelist is Dr. Chun.
Hello, hi. I'm from Singapore.
Okay. And Dr. Chris Evans and Dr. Lee from the Busan National University. All participate all the convention. And Dr. Nishina may can induce the first presenter.
Okay, thank you, Dr. Chang. I'm Dr. Nishina from Tsukuba Medical Center Hospital, Japan. So let's get started. And the first presentation will be by Dr. Janorkar from India. And his title is Percutaneous Coronary Intervention of a Disappeared Right Coronary Artery Caused Due to Iatrogenic Coronary Artery Dissection, Importance of Over-the-Wire Balloon System. Okay, so Dr. Janorkar, would you like to start your presentation?
Thank you very much. Good afternoon, everyone. This is not very exotic case, but nonetheless, it is worthy of discussion. It is iatrogenic coronary artery dissection of right coronary artery we tackled with PCI. And I'm giving special emphasis on the importance of over-the-wire balloon system in this case. I do not have any potential conflict of interest to declare. This is 50 years old female without any risk factors, presented with chronic stable angina, increase in intensity since a month. ECG showed STT changes, echo was normal, treadmill test was strongly positive, body surface area 1.45 square meter, biochemistry was normal. So this is chronic stable angina, stress test was positive, which compelled us to do angiogram, and angiogram showed this. Left main was totally normal, LAD calcified vessel, having significant lesion in mid segment, as you can see here from various angles. I have not shown all the angles here. Circumflex is showing lesion here, 70-80%, and RCA dominant and some ostial mild plaque. So everything was okay here up to this juncture. My fellow was doing angiogram, and suddenly I saw STT segment changes, ST elevation on the monitor. Quickly, we took 12 lead ECG, it showed ST elevation in inferior wall leads, and patient started having angina. And my fellow went in and saw with diagnostic catheter after 5-10 minutes after finishing the angiogram, and we saw this. So this was massive spiral dissection of right coronary artery right from ostium. You can see here. And patient experienced significant angina along with hypotension at this juncture. So my fellow went in at this stage and saw this acute closure of RCA. RCA just disappeared. He attempted to wire, but here to no avail. So I took a deep breath here. I contemplated the situation and took a wider guide catheter and went in and took OTW catheter system because of past experiences. We faced such situation. So I did for sinus injection, which showed no retrograde dissection at all. So this was quite okay here. Patient started having brady arrest with inferior wall ST elevation here. So I quickly took hydrophilic wire with OTW catheter system, 2 into 12 millimeter balloon, and advanced the wire carefully with good support of OTW system into the true lumen. And here you can see I could get into true lumen with good support of OTW system, pre-dilated with 2.0 into 12 millimeter OTW balloon, tacked it initially, but dissection wouldn't heal. So I went straight away with 3048 millimeter DES to cover both exit points, proximal at sinus and distal in distal segment. And after that, post-dilated the stent and showed beautiful result. So you can see final result, TIMI3 flow and RCA flowing nicely, and catheter and dissection is healed properly. the stent covering the whole thing. In a nutshell, it was like this when my fellow was doing angiogram, mild plaque, almost normal right coronary artery. It disappeared totally within few seconds, and we could tackle that with OTW catheter and long stent. So at this juncture, I myself asked a couple of questions, cause of the complication, available options to tackle the situation, why I chose this strategy, and stenting of whole length or just mouth of dissection. I'm going to answer this question in next slide, but I want to give emphasis at this juncture on an OTW catheter system. It can help us in various ways. We can enter into the true lumen meticulously, where OTW system can give us good support. We can inject contrast material, and it guides us, guides the guide wire meticulously entering into true lumen, and we can advance wire slowly into true lumen. We can exchange the guide wires also if we want through OTW system. If we don't get into true lumen, we can always enter into false lumen, which is little easier, and through the OTW system, and we can aspirate the hematoma. There is actually hematoma collection in false channel. So we can aspirate the hematoma, false channel collapses, and simultaneously we can enter through right at the ostium with another second wire into the true lumen. So parallel wire technique or double wire technique after aspiration of the hematoma from false channel, or you can enter into false lumen. Again, it is easier with OTW system, aspirate the hematoma and puncture the false lumen and re-enter into true lumen with stingray balloon or something like that. So we can always use OTW system, OTW catheter, balloon catheter in various ways, or else we have to call the surgeon, but it is always better to tackle this situation in catheterization laboratory. So coming to the end, this is my last slide. Take home message is iatrogenic coronary artery dissection during CAG is rare. It happens mainly during intervention with guide catheter, but during CAG is rare, less than 0.2%. Deep catheter intubation, manipulation, non-axial positioning of tip, forceful contrast injections may cause it. One of the reasons has caused it here. Guiding with larger curve, 4 to 4.5 is advisable. Sinus injection is imperative before you enter into true lumen, because to check the retrograde dissection, if any, there was none here. We were fortunate enough. Hydrophilic wire is always useful with extra support to track the true lumen through OTW system. OTW system can be used as an additional support for the wire and also to administer contrast to confirm true lumen. So meticulously we can advance the 0.5 millimeter by millimeter into true lumen while advancing the wire, and OTW system helps to exchange the wire. We can exchange this wire with our workhorse wires afterwards. Stenting of entire length, this can be debatable, but stenting of entire length of the dissection is advisable depending upon the past experience we faced, to cover both exit points. There are two exit points when we face such dissection, spiral dissection type F, proximal at sinus and distal in distal segment. And of course, the surgeon backup is required, but we always try to finish this case in catheterization laboratory. Thank you very much.
Okay, thank you very much, Dr. Janorkar. And very nice bailout, I think. So is there any question or comment from the panelists?
Okay, maybe I'll start the ball rolling. Hi, it's Chee here from Heart Center in Singapore. So nice case.
Thank you.
And as usual, it's usually the fellow, I hope, that causes these complications. So I remember I had one or two of these as well. So maybe a few questions, but I think my first question is, you mentioned hydrophilic wire, and this is your choice of wire for dealing with these dissections?
Particularly, yes, in such type of dissections, it always is handy and helpful. We can track the true lumen properly with hydrophilic wire. That's our experience, yes.
Yeah, because I think there is a counter argument sometimes that the hydrophilic wire tends to go into the false lumen a bit easier. Yeah, so I mean, my experience is actually I prefer hydrophilic wire, but I don't know if the rest of the panel.
I always have been doing that since many years, and it's quite handy.
And may I be permitted one more question?
Yes.
What is your? I mean, you very nicely demonstrated you were in the true lumen. Do you have any experience with using maybe a cutting balloon at this point to try and fenestrate and create more channels between the true and false lumen, and maybe then you can get away without having to stent?
No, I'm sorry, I never used cutting balloon. Can be helpful in some situations, but once we tried with puncturing from false channel into true lumen and used a stingray balloon once, but never cutting balloon. No.
I'm Siti. Hi, I'm Siti Khairani from Malaysia. Thank you, Dr. Janorkar, for the nice presentation. But I mean, during that event, do you need a temporary wire in between, or it was very fast?
No, we didn't need that actually. Once we went straight away went into true lumen and tacked the dissection, patient started responding. So hypotension improved, the bradycardia improved. Once we needed atropine, but we never used temporary wire. No, we didn't do that.
Great, great.
Any other question or comment? Dr. Janorkar, would you consider using IVUS in that situation? Because in Japan, as you know, we always use IVUS, and sometimes IVUS is very, very helpful.
Yes,
I think it's a little bit better than injecting the contrast into the lumen when you are not very sure.
Yeah, so we have limitations with contrast. Yes, we should not inject at all, because otherwise the propagation of dissection, it extends up to crux and beyond crux also. IVUS is helpful. We used that in one case, but here, the situation was so terrible. I mean, we were a little panicky here. Patient was sinking, brady arrest, so we didn't have much time. So I was a little lucky to enter into true lumen actually without IVUS and without other modalities. So. We don't, but I would like to use IVUS. Yes, it is quite helpful.
Can I make one final point? Okay, my quick point is that obviously prevention is better than cure. So I think in this case you can see that there's some osteal disease and not a lot of contrast reflux when you did your diagnostic. So the fellow needs to be very careful in these kind of situations. Always a hazard.
Yeah. I'm going to add a comment, and most of the cause of dissection is due to contrast agent. So in some animal models, to make the aortic dissection, we can use the radio contrast agent.
Yes.
And then after powerful injections, we can make the aortic dissection model. So radio contrast agent is a slightly dangerous product into the vessel. So cautious injection is a very important point.
I agree with you. Yes.
Okay, thank you very much for a very active discussion. Unfortunately, we are a little bit behind of time, so I would like.
Thank you very much.
Yeah, thank you very much, Dr. Janorkar. Very good job.
Thank you.
Okay, so the second presentation is by Dr. Abdullah from Malaysia, and the title is Calcified Descending Aortic Dissection During TAVI. Okay, please go ahead.
Hi, thank you for the introduction. I'm Dr. Faizal from Malaysia. So I'll be presenting on one of the case. It's more of a complication of a procedure, of a TAVI procedure that we have done. So this is I have no conflict of interest. So this is the patient, 76-year-old female with a known ischemic heart disease 20 years back. And she has underwent bypass with a 3 SVG. And this patient been coming with the recurrent admission with the acute pulmonary edema. There was no chest pain, there was no syncope. And on examination, BP was a bit high side. And we also noted that there was an ejection system murmur relating to the carotid, which is suggestive of aortic stenosis. And true enough, echocardiography showed severe aortic stenosis with a valve area of 0.6 centimeter with a mean pressure gradient of 51 millimeter mercury and max PG of 91. So at this point of time, we have given option, and this patient opted for TAVI because she already underwent a bypass before. And so we have done a workup for a TAVI, and graft study showed all grafts were patent, and a bilateral iliac artery angiogram showed both are heavily calcified, which left iliac was worse, and the osteal size was 4.7 to 9.2 cm on the right side, and left iliac showed 3.7 to 7.5 cm, and this aorta also was calcified as well. And so we had a CT angiogram done, the TAVI protocol, and there was both iliac was calcified, and lumen size, mean lumen size of the right iliac was slightly bigger than left. So at this point, with the discussion with the company, which was the model that we have chosen was for a Medtronic TAVI, and we decided to go for the Evolute 23 millimeter as our TAVI device. So the procedure itself was done under general anesthesia, and approach was bilateral femoral puncture with main device from the right side, and bilateral femoral puncture with 6 French with pre-close with 2 ProGlide from the right side, and this we have upgraded the right femoral 6 French to a 12 French sheet, and pre-dilate with a 14 French sheet before we advance the TAVI device. And from this video, you can see whenever we were hitting this calcium chunk with the dilator, 14 French dilator, and we realized that we will have difficulty to pass the TAVI device without intervening this part of the session. So what we did, we pre-dilated with the peripheral balloon, 5O balloon, which we went above nominal, and the size is around 5.2 mm. And then we decided to insert the main device. So this is the main device. As you can see, it's the main device, the triangle, the cups there, it keeps hitting the calcium. And we know that the 5 millimeter is the minimum diameter required to pass the Evolute device 23 size. So we probably push a little bit hard, hoping that it will pass through the device. And as you look closely at this calcium chunk, so when this happened, when we pushed a bit further, this happened. So the whole calcium chunk moved with the TAVI device. So at this point, we knew that we were in some kind of trouble. The worst case scenario is the calcium chunk strips off the whole of the aorta and causing a major perforation. And this is the immediate shot that we took, and it showed the dissection of the aorta below the renal artery, fortunately, and there was no any effect to the distal flow. So at this point, we took out the TAVI device and we pre-dilated with the 6O balloon, and we managed to deploy the TAVI device successfully. And this was the final shot before we came out. And as you can see, there was no extension of the dissection. The distal flow was good. So at this point, we decided to stop here and observe and repeat the CT angiogram as an outpatient to see the progression of the dissection, whether it's any aneurysm that may have performed in the future. So with the delivery system, with the 14 French sheet, the internal diameter is 14 French, but outer diameter is 18 French. So the minimum vessel diameter is required is 5 mm. So this is the basis before we pre-dilated. So we have pre-dilated the 5.0 with higher pressure with the 5.2. So we thought it was enough, but in truth, it wasn't enough. And the calcium distribution was much heavier than how it was seen in a CT angiogram. So the conclusion is aorta calcification is commonly seen, especially in elderly, where the most common age group TAVI being performed. In this case, the severe calcification at distal aorta, which was underestimated. And though initial reports said that it was enough space, and however, the extent calcium was so extensive, it did not allow our device to go through, despite of pre-dilatation. And pushing any large device across a severe calcification need to be done carefully, as stripping of calcium could be a life-threatening. In this case, we were fortunate it did not cause a major perforation and only end up having a non-flow limited dissection. Thank you.
Okay, thank you very much. Very tough case. And can I ask you one question? So did you complete the TAVI or just start the procedure?
Yes, we have completed TAVI, and the final picture was before we came out.
Okay, thank you very much. So this paper is now open for discussion. Any comments or questions from panels?
I have some comments, and in this patient, is a problem is combined the problem. Not only this patient has two problems, severe calcification, and another is right common iliac artery also angulation. So you can see your wire is attached to the right common iliac artery, distal portion right common iliac artery, the medial side, and distal aorta is lateral side. Is wire is like this, because of calcification and another angulation. So it is not important lumen size, just the lumen size, and angulation. If a patient have angulation and calcification, you have to have a more lumen size and the 7 millimeter or 8 millimeter. If a patient have calcification and angulation, because wiring along to the side wall, just side wall. So it is difficult to advance. It is difficult to advance the TAVI device. So and then another option is you can use the angioscript balloon to collect the calcification. It is safe to use the common iliac artery, and then I recommend this is in this patient 7 millimeter may be sufficient in this patient. And another option is a cutting balloon, and many times cutting balloon. One time is not sufficient, is not enough. Is most 3 or 4 times more than cutting balloon. And then you have to prepare the graft stent for right common iliac artery to prevent perforation.
Yeah. Yes, I do agree. We have obviously we have underestimated the lumen size and also the extent of calcium, and I do agree. A bigger, larger pre-dilatation will definitely improve in passing across the device and prevent this complication.
And also you don't have to worry about the dissection. It's a descending type P aortic dissection. So it may be resolved spontaneously.
Yes, I agree with you.
Okay, is there any question? Because we are reaching the time limit.
I have a question. Is there any role of long sheath in this case? Long sheath, using long sheath?
Actually, for TAVI, we don't usually use a long sheath because to prevent because the sheath of the TAVI itself is already large enough, 18 French. So to use a long sheath, we don't have available, and it will just make the lumen much larger. So yeah, we do not have that.
Okay, thank you very much. Very good case, and we have to go to the next presentation, and the next presentation is by Dr. Iryuza from Indonesia, and the title is Rescuing Occluded Side Branch During CTO PCI. Okay, please start your presentation, please.
Thank you very much. Let me introduce myself. My name is Nanda from Indonesia. Today I would like to present my case, which entitled Rescuing Occluded Side Branch During the CTO PCI, the role of a gel balloon technique. So I don't have any potential conflict of interest. So as for introduction, according to the Han et al. In 2013, side branch occlusion during the provisional stenting has a remarkable impact of to death, MI, or even MACE. So as for case illustration, the patient was a male, 57 years old, with chief complaint of chest pain during exertion. He's known to be hypertensive and diabetic. ECG shown sinus rhythm with poor R progression at V1 to V5. The echo shown 36% of the ejection fraction with positive regional wall motion abnormality, and he had a history of the NSTEMI 2 months prior to the current hospital admission. So from the diagnostic angiography, we can appreciate that the left main was normal. There was a CTO at the proximal LAD with the distal part filled from the ipsilateral vessel. At the circ, we can see the subtotal stenosis at the proximal part and significant stenosis at the OM branch, and the RCA was dominant with remarkable stenosis at the PDA branch. So we decided to do PCI by single arterial access from radial artery. The XB 3.56 French was used with the antegrade CTO approach. Wire escalation from soft to hard wire as needed, and the rest dilatation, stenting, and post-dilatation if needed. So we crossed the CTO lesion antegradely with XTA wire, back up with a microcatheter, and the microcatheter tip injection showed the contrast filling to the true lumen at the distal of the LAD. So after exchanging the wire with soft wire, we did a pre-dilatation at the LAD from the mid to proximal with the 2015 millimeters semi-compliant balloon. And then after the pre-dilatation, the angiography shown a long LAD lesion with non-limiting flow dissection. And also we found that the diagonal 2 side branch was in high risk of occlusion there. Therefore, we planned to deploy 2 stents at the LAD, and we would protect the diagonal 2 branch with wire and balloon. So the stent deployment was done with 2.5 33 millimeter stent at the mid LAD, and we also pre-dilated the lesion at the mid to proximal LAD with the stent balloon. So after the first stent deployment, the angiography shown the TIMI3 flow with no dissections or no thrombus. However, we found that the diagonal 2 branch was occluded. So we plan to expand a small balloon at the diagonal 2 and deploy the second stent with jailed balloon technique to rescue and avoid further occlusion of the diagonal 2 branch. And here the patient started to suffer from chest pain, and we give the patients a nitrate in this case. And then jailed balloon technique was performed with simultaneous inflations of the second stent and this 2O balloon at the proximal diagonal branch, and the stent was overlapped with the first stent implanted previously. So after the second stent deployment, we can appreciate that the side branch was rescued and the flow to distal diagonal 2 has returned. And finally, we retrieved the jailed wire, and patients became more relaxed in this point, and then the chest pain was gone. So we performed the final part to optimize the stent expansion at the proximal LAD with NC balloon 3.5 12 millimeters. And finally, we did the last angio, which shown the flow to distal LAD was good, as well as the flow to the previously occluded diagonal 2 side branch. So based on several references that there are several side branch protection techniques, such as jailed wire, jailed uninflated balloon, jailed inflated balloon, jailed microcatheter, and modified jailed balloon. In this case, we did the jailed inflated balloon technique to rescue the occluded diagonal 2 branch. And we see at the right side of the screen from the study by Jean in 2019, the jailed balloon technique is associated with significantly lower rates of the side branch occlusion. And then the jailed balloon technique is safe and really effective technique that may have an advantages over the jailed wire technique. So in conclusion, the bifurcation PCI is technically challenging and associated with higher frequency of adverse outcomes. Second, side branch occlusion is a serious complication of provisional one-stent strategies, and the jailed balloon technique is safe and beneficial in provisional stenting strategy to avoid the side branch occlusion. Thank you.
Okay, thank you very much, Dr. Iryuza. Very nice case. So, any comments or questions from the panels? I think now this technique is getting more popular among the interventionists.
Thanks for the presentation. I have to confess that I can't see the images that well, but actually, how big is this second diagonal? Was there a thought to maybe have a two-stent strategy to actually stent the diagonal rather than a provisional crossover strategy? And my second question is, why do you choose the gelled balloon versus the modified gelled balloon technique? Is there any special reason for that?
Yeah, thank you. For the first questions, I think the side branch, the diagonal to branch, is about maybe in between 2 millimeters, I think, between, maybe less than 2 millimeters. So we decided to do the side branch protection to avoid the side branch occlusion. And then the angle was a bit sharp in this case. And then also for the second questions, why we didn't do the modified gel balloon. So because in modified gel balloon, sometimes the balloon and the stent was not kissing really well. So the modified gel balloon, it separated in between the balloon and the stent balloon. So to do it more safely, I think classic gel balloon technique to preserve the side branch is, I think, safer in this case, I think. And maybe additionally, the gel balloon in modified gel balloon technique, there's a risk of difficulties in pulling the gel balloon and also the gelled wire, I think, maybe. Thank you.
Okay. Iryuza, do you put a stent in the region, have any image study for? Because maybe you can show the diagonal ultimately have the region, and if a post stent, maybe a port for proximal and the rewinding, maybe have another choice for avoid the stent flow.
Yeah, thank you for your suggestions. I'm totally agree with the use of the imaging. I think it could help the operator, I think, to optimize the stenting, and maybe in between the procedures, I think if the imaging was done, maybe the strategies also can change, maybe one stent or two stents, and then we can evaluate the expansion of the stent, whether is it good or not. Thank you very much for your suggestion.
All right, so no more question. Okay, thank you, Dr. Iryuza. So let's go to the next presentation. Thank you. Okay, so the next one is by Dr. Sandana from India, and his title is PTA of CTO of subclavian artery, radial and femoral root. Okay, Dr. Sandura.
I have no actual or potential conflict of interest in relation to this program or presentation. So this patient was a 70-year-old male, known case of diabetes, coronary artery disease. He's a post-PTCA patient, post-PTCA to RCA, distal left mid bifurcation. He was presented to us with complaints of right upper limb claudication, and CT angio was done outside, not in our hospital, showed right subclavian artery 100% occlusion. So he came to us with the history of right upper limb claudication, and on examination, the right radial pulse was feeble. His BP was 146 by 84 millimeter of mercury, and chest and CVS examination were within normal limits. And ECG showed right bundle branch block, sinus rhythm. Echo showed RWM in the RC territory with EF of around 50%. His coronary angiography revealed patent left main and RCA stents, and peripheral angiography revealed right subclavian artery 100% occluded. So plan was to begin with was to start with PTN stent to right subclavian artery from radial and femoral approach. Because it was a total occlusion, so that's why we planned to begin with the dual approach. So the route was right radial and right femoral. So this was the first shot. You can see from the radial artery we took this angio. It showed right subclavian artery. It was 100% blocked. So what we did was we took a guide catheter from the right radial artery. We tried to cross retrogradely using first we took the routine wire, our choice floppy wire, but it didn't help. So we took a Gaia 2 wire with a Corsair support. This was a shot, and we were able to cross a bit with this Gaia 2 wire with the help of Corsair. Then later on, we on the other side, we were checking with the taking shot from right femoral artery also. So after crossing the Gaia 2 wire, we exchanged it with the thermo. We took a thermo 0.35 millimeter wire. It was passed retrogradely, as you can see from this shot. And we are taking our antegrade shot also from the femoral side. So this thermo wire, we move it downwards towards the femorals, and with the help of snare, we snared it from the right femoral root, and an 8F long sheath was put over the thermo guide wire. So this, we can see that from this shot. Oh, sorry. So thereafter, we pre-dilated it, and we put a 8 by 6 by 40 millimeter exact self-expanding stand deployed after pre-dilatation. This was a shot in which we putting the stent, and this was the final shot from the femoral root. It was a good flow, as we can see that the subclavian artery is nicely opened. And to conclude, there are 4 types of subclavian total occlusion: rat tail type, peak type, hilly type, and plain type. A rat tail type, that there is a tip with some flow can be seen across the occlusion, and the peak types are they are usually done through transfemoral routes because we can see a bit of entry point out there. But this hilly type in which there is a concave proximal cap, and plain types are usually crossed through retrogradely, because if you go through the femoral route, that the wire support is not very good, and exactly we didn't know where we have to enter. So retrograde approach from radial route or the right brachial route can be tried for these rat tail and peak types, hilly types and plain types. The present case is of a hilly type with a proximal with a concave proximal cap, and it was done through dual route, which started from, we entered the true lumen from the radial route and ultimately finished the procedure from the femoral route. And as stent was 8 millimeters size, so it cannot be, we took a 6F sheath in the right radial route. So we have to snare this thermo wire to the femoral route, and we have to implant the stent from femoral route. So thank you, sir.
Okay, thank you very much, Dr. Sadana. Very elegant work. So are there any questions or comments from the panels?
I'm going to add some comment, and you'd better check the brain CT angio or MR angio before procedure. And then if a patient have left vertebral dominant system, you would better you would better use the protective device for right vertebral artery. If a patient have a right vertebral non-dominant system, you don't need to worry about that. But yes, if most of the case in this procedure and experienced micro impact through the right vertebral artery. And then in this procedures, I wonder, I ask you some question that you don't need to approach the femoral artery, because you can use the procedure through the right brachial artery directly. So yes, the narrowing procedure is so complicated, I think.
Yes, I fully agree, sir. I fully agree, sir, because we took the radial route to begin with. That's why, sir, we have to take this femoral route just to implant the stent. Otherwise, if we could have done it from the right brachial route, then this procedure from the right femoral can be saved. So.
Yes. Most of self-expandable stent is comparable for 6 branch. So it is possible through the radial artery. Most of self-expandable stent up to 10 millimeter is comparable for 6 branch. It is available.
Okay.
Thank you very much. Any other question or comment? Okay. Okay, so thank you very much, Dr. Sadana. So move to the final presentation by Dr. Arif from Malaysia. His title is the Poseidon Trident. So Dr. Arif, please go ahead and start your presentation.
Hi, and a very good afternoon. So my name is Arif. I'm from Malaysia, National Heart Institute of Malaysia. So the title of my presentation is the Poseidon Trident. So basically the reason why I chose this title is because this is one of the first things that came through my mind when I first took the shot of the patient's angiogram. So I have no disclosure for this presentation. So this is a 57-year-old gentleman with a background hypertension, dyslipidemia, and chronic kidney disease. He was been admitted to a peripheral hospital for non-STEMI with a high GRACE score and also with cardiogenic shock requiring intubation. And then we took over this patient to our center for urgent coronary angiogram. So a bit of non-invasive test. The EF is very poor, only 22% with global severe hypokinesia. But the RV function is relatively still okay with dilated LV. So we managed to actually do the viability study, actually show a large area of transmural infarct over the distal LAD. So basically from the angiogram, there's a tight stenosis over the distal left main with a class Medina of 111, which involve also the focal stenosis over the ostial LAD and ostial circumflex. And we are very grateful that the RSA is rather okay. So if you can see from the images here, from the caudal view, it's a very tight stenosis over the distal left main, a focal stenosis, and the rest of the vessel actually appear quite okay. And the OM actually bifurcates very early over the circumflex, and from the cranial view, it demonstrates very well how tight and how hair thin is the stenosis. And the RCA here actually showed that the vessel are relatively well preserved, actually supporting with the collaterals towards the LAD. So we actually proceed with the IBP insertion, and then case was referred to surgeon for urgent bypass, but however, they decided not to actually proceed with it because of the high risk in view of the poor cardiac function. So after 1 week of the index procedure, we actually proceed with the high risk PCI. So the plan was actually to access from the left femoral artery with the JL4 as the guiding catheter and to wire both LAD and circ, and also the initial plan to actually just to stand the left main LAD after we predilate both branches. So as you can see here, there's a tortuous femoral artery in which we have to actually insert this arrow shape for a better support. So run through to the circumflex and filter XT with the fine cross towards the LAD. So there's a pre-dilatation done sequentially with a small balloon, 1.5, and also subsequently with the NC balloon for both the arteries. So this is the end result after the pre-dilatation. And the left main LAD was stented with 3.5 23 stents. So this is the stent deployment. So, and then we post-dilate and further doing POT with the NC balloon 4.0. So as you can see here, from the images here, after the post-dilatation, we can see there's a haziness over the ostial circumflex. So during that time, we were a bit hesitant to actually just leave circumflex like that because the fear of the occlusion. So we decided to actually stand the circumflex. So we removed the wire from the OM, the gel wire, and the rewire with the new wire. So we further predilate with the 2.5 balloon. And then after that, the left main circumflex was stented with the 3.015 stent and post-dilated with the stent balloon at high pressure. So, and then we further crush the left main circumflex stent with the NC balloon 4.0. We call it as a reverse crush. And after we reverse crush the stent, we were having actually difficulty to pass the balloon to circumflex for the post-dilatation. So there were a few maneuvers that we did. So in the end, after we changed the JL4 to EBU catheter, you can see that we can finally pass the small balloon to the circumflex. So we further post-dilate the stent with a 3.25 balloon. And then after that, we kiss with the 4.5 over the LAD and 3.25 over the circumflex. And we finally POT with the 4.5 balloon over the carina and the left main. So this is the end result after the final POT. So you can see that the circumflex and LAD artery are widely open. And also from the caudal view here, you can see that there's a bit of maybe some nodular calcification there, but we already went high pressure, so we are quite happy with the end result. And then this is the spider view of the angiogram. So patient was well discharged after 4 days, and the last time was 1 month ago. He was doing very good. the functional status is rather okay, 1 to 2, with no symptoms of angina. So there are a few discussion points that I would like to highlight. So this is definitely a cheap procedure. Support in terms of the IBP is very instrumental, and we are lucky to actually have a very good right spot. And then our aim from the beginning is to actually keep things very simple and to actually reduce the ischemia time. And if let's say there are other things that we might to actually consider, is also the use of the intracoronary imaging in a form of IVUS or OCT. And if let's say needed, maybe the consideration of an atherectomy device. So the other question is that whether we want to actually proceed with either with the provisional or the bifurcation stenting. But we committed in the first place to actually just proceed with provisional stenting and pop out the side branch because of the Dimitri flow over the circumflex and to actually reduce the ischemia, less metal layer. But then we decided to, in the end, to bail out the reverse crush because of the fear of the occlusion of the circumflex branch. So of course, the disadvantages of this reverse crush technique is that the crush stands inside within the main branch, and of course the difficulty to recross back the side branch stand as demonstrated earlier. So and then if we were to actually proceed with the decay crush or culotte for the bifurcation stenting, decay crush will be the favorable one because of the position of the crush stand is outside the main branch. So we were having difficulty to actually pass the balloon to the side branch. There are a few possibilities: known coaxial catheter, wire entanglement, suboptimal stand expansion, but it was solved well with the ABU 3.5. So this case actually illustrated the high morbidity and mortality in patients with very severe coronary artery disease with poor heart function who just survive a high-risk cardiac event. So the approach for this case is to actually not to complicate things, to keep things simple, and actually to prioritize patient safety. And then it is also very imperative for us to actually being very dynamic and sharp in handling whenever the less favorable outcomes occur. So I have to emphasize that the use of intracoronary imaging is essential because it will provide us with added value in terms of vessel sizing, characteristic of the vessel, and cell position. Thank you very much.
All right, thank you, Dr. Arif. Very nice presentation, very challenging case. So are there any question or comment from the panel? This is the final presentation.
Yeah, hi, Chee, Tang here again. So nice case. I guess my main concern or my main challenge in this case is, as you brought up, is whether or not to treat that circ, right? Yes. Did you do any pre-imaging of the circ at all to you know, like Dr. Chiang mentioned in the previous cases to help to guide that, and how? Because I think you mentioned you were scared that you would close off after you stented left main to LED, but how did you decide that? What were the factors?
Actually, we have no objective assessment of the intracoronary imaging, to be honest with you, for this case. Ideally, we would like to actually do the IVUS, but however, during that time, it was not available during that point of during that juncture. So the reason why we actually proceed to actually stent the left main circumflex is because eyeballing from the coronary angiography point of view, there was a bit of haziness over the circumflex, and then actually the size of the ostial is rather big, and then it actually supply quite a good territory of the lateral, and then we afraid with that kind of poor heart function, the patient can afford to actually lose that branch. So it was a bit of the clinical judgment altogether. So based on that solely, without the objective assessment of the IVUS, we actually decided to stent and reverse crush the left main circumflex.
Yeah, because our Korean colleagues have a lot of experience with left main and whether or not to stent these kind of ostials, because the ostium of the circ always looks a bit funny after you've placed that left main to LED stent, right?
I agree with you.
Yeah. So, Dr. Lee, what do you think? Would you have stented the circ? Yeah, Dr. Lee, I was just saying, would you have stented that circ after the left main LED provisional stenting?
I have some question is about in this patient is I'm searching for the device is which hemodynamic support device would be helpful in this patient. Is IBP. First one is IBP and small profile ECMO, and another one is left ventricular assist device. So I don't know exactly. I can remember the name left ventricular is operating system. Impella, yes, you're right. I'm searching for the device. Impella is, I don't know exactly which one is better in this case. Is a very low ejection fraction. What is your question? I'm sorry, Dr. Chin.
Yeah, my question was, would you treat the circ after the left main stent? Because I know in Korea and in Japan, there's a lot of left main stenting done, and I think you have come up with your algorithm about whether to treat or not. Yeah.
Yes, yes. I'm concentrated on my topic. I'm sorry. So is in Korea. In Korea is most of doctors is prefer the one stent strategy. If a patient have a big complex, is modify the T stenting, is a provisional T stenting, is or small overlapped T stenting, is currently we don't use the kissing or crushing techniques in Korea. Is data is not good, so is most of patients prefer the one stent strategy, or if a patient have a big circumference, is prefer the two stent strategy by small overlapped T stenting, and then kissing balloon. Okay, I'm sorry, I missed your question.
Okay, thank you very much. I think in Japan, if I were the operator, I would have stented into the circ, because in this patient with severely reduced airway function, even compromising flow in circ could be catastrophic. So, and the patient had very good distal vessel, LAD in circ was quite big, and left main is quite big. So probably I think, either strategy, two-stent strategy may work for this case. So I would have. Okay. So thank you very much for attending. And I think we are out of time. And I think it was very nice cases and very nice discussion. So thank you again for attending this session, and hope to see you very soon in person. Okay. Thank you very much.